I have assessed a patient who insisted they just sprained their ankle and attempted to continue trekking for 4 hours. The x ray at hospital confirmed a displaced distal fibular fracture. I also have evacuated a patient by stretcher over 8 hours for what turned out to be a grade 2 sprain. Both of these outcomes were suboptimal. Here's the clinical tool that helps you get this right. So, in the wilderness, without x ray, the Ottawa ankle rules give you validated clinical probability guidance that can be applied anywhere with no equipment. So, the Ottawa ankle rules: an x ray is indicated, meaning fracture should be suspected if there is pain in the ankle and any of the following. So, point bone tenderness at the posterior edge or tip of either malleolus, inability to take 4 weight-bearing steps, both immediately after injury and at the time of assessment. So the point tenderness test. So you will use one fingertip, not your palm, and press firmly and precisely over the bone. If maximum tenderness is directly over the bony landmark, that is consistent with the fracture. If maximum tenderness is over the soft tissue between the malleolus and the midfoot, that is more consistent with the ligament injury. For the weight bearing test, can the patient take full steps, placing weight through the injured foot, both immediately after the injury and at the time of assessment? If the answer is yes to both, fracture probability is significantly low. If no, treat as fracture, splint and evacuate. The clinical rule for uncertainty is when you cannot distinguish with confidence in the field. So manage as the more serious option. The consequence of undertreating a fracture exceeds the consequence of overtreating a sprain. Two tools: one finger for palpation, 4 steps for weight bearing. Apply them systematically. Document what you find. And when in doubt, you splint.